Hi, welcome to OHRPP's Learn at Lunch. Today we have wonderful guests. We're going to talk to us about research recruitment services at the CTSI, Office of Clinical Research. We have Antonio Petrus and Lily Johansson. So please take it away.
Thank you so much, Moore. Hi, everyone. So as Moore mentioned, I'm Antonia Petrus. I'm the Director of Embedded Clinical Research and Innovation Unit in the Office of Clinical Research, CTSI. And with me today is Liliana Johansson, who is the Senior Project Manager over Research Recruitment Services. Today, we will be covering research recruitment services that are available for all of you today in our research community here at UCLA. There we go. So what our agenda is for today, we're going to be covering the importance of recruitment tools, recruitment tools, selecting the right recruitment tools, then talk a little bit of background on Epic-based, what Epic-based research recruitment is, then about our recruitment registries, then focus specifically on the UCLA Epic specific tools you have available for you today, the feasibility and intake process of putting in a recruitment request to use these tools, then cover UCLA recruitment registries that you have available for you, and talk a little bit about the sensitive population caveat on using these tools when your cohort includes sensitive populations, and then wrapping up with how to submit a request to use these tools. We're going to be pausing every several slides to make sure we give a little bit of time to ask questions, but feel free to add questions or comments in the chat. Both Lily and I will be monitoring throughout the presentation and seminar. All right. So to begin, why is it important to select the right recruitment tool for you? So really, it's the foundation of having a successful study execution, whether you're submitting a grant or you already have study in place. Making sure you select the right recruitment tool as early as possible really ensures high quality data and study outcomes. It is also an efficient way to use your resources. The last thing you want to do is use a certain recruitment approach and realize months or a year or 2 years later it doesn't work and you have to shift gears to a different tool and try to come up with resources on how to cover that recruitment effort. It also proves to have using the right recruitment tool can really get better success in grant and funding approvals. Another thing is really, it really meets regulatory and ethical considerations when you're submitting IRB or for compliance and data use agreement, is making sure you have the right tool and format for recruitment. As most of you know, obviously also using the right recruitment tool can really increase the diversity and representation in your cohorts, really improving the generalizability of your findings. So what's Epic-based research recruitment? It utilizes electronic health records. For us, it's Care Connect to identify potential research participants. With these Epic-based research tools, researchers can filter participants based on structured data such as diagnosis, medication, lab results, and upcoming appointments. Recruitment outreach can be done through MyChart messaging and clinician referrals. We are going to be covering these tools in detail later on in the presentation. And using Epic and Care Connect really can help researchers efficiently target study-eligible patients already receiving healthcare in our medical system. Some of the limitations of using these tools that I want you all to keep in mind is it is limited to structured EHR data. It may not capture lifestyle factors, anything that can be captured in notes or any other types of like other eligibility criteria where you would need to dig deep into the chart. It does require specific approval requirements such as data access agreements and other committees that approve using these tools. Something to keep in mind, there is a data lag and incompleteness that we find in EHR. So medications or diagnosis records sometimes are outdated and potentially excludes eligible patients when you're really using these tools. It is limited, as you can imagine, to the health system patients. So it may limit you in really reaching a broader underrepresented population. And that's where recruitment registries can really come in. So what they are, They're voluntary databases where individuals sign up to be contacted for research opportunities. So these can be patients, we have students, or other members of the community. Participants, when they join these registries, they provide self-reported health information, and they also provide what's the best way to contact them and what's their research participation preference. Do they want to hear about study opportunities specific to that registry or broader research opportunities? With these registries, researchers can efficiently search for and contact pre-consented individuals for conditions such as mental health, diabetes, and other types of diseases that those registries have been constructed around. It is a useful tool, a useful approach to engage very motivated participants who may not be active patients at UCLA, but could be great for meeting your cohort targets for your studies. Some of the limitations with using these recruitment registries, it does rely on self-reported data, so may lack some clinical verification. And those also can be outdated over time. It really depends when the individual registered to be part of that registry and completed their survey. There is a potential bias because these participants are very engaged with research. So it may limit you engaging sort of a broader population that may be less likely to engage with that type of treatment or study. It is limited access to real-time health updates since it's not linked to any EHR-based tools. So what are the UCLA research recruitment tools available for you today? I'm going to be just introducing them, and I'm going to navigate to Lily to dive into the details of all these tools. But essentially at this time, we can offer 3 general tools. We have a MyChart research recruitment outreach, which is direct to patient outreach using the health patient portal. We have a reporting workbench. This is a customized report that's built with an Epic. It's custom to your criteria, and it would give you access to individuals that meet your study criteria that have upcoming appointments, or maybe are admitted to inpatient units. Then last, we have a best practices alert. This comes such as pages, emails, alerts, provider-facing alerts, and they're really customized to your study population as well and criteria. So Lily, if you want to dive into a little bit more of our Epic tools.
Yeah, so we wanted to point out a few of the features when using these research recruitment tools. Obviously, there's efficiency and time saving because these are identifying your cohort and the background and not needing you to screen on a one-on-one basis. We also have seen improved patient engagement because with the MyChart tool, you are integrated with the clinical care system compared to a cold call or email. We also have more enhanced data accuracy and integrity, again, because we are using the electronic health record. And definitely cost effectiveness. As I mentioned, it does decrease your coordinator's effort with either screening or recruitment. And so that's definitely a plus. And with these tools, you are going to be meeting UCLA's compliance and regulatory requirements. And additionally, we are able to support multiple study cohorts if that is something that your study is in need of. We did want to point out that for all of these tools, because we are using the electronic health record, to define and identify your cohort, we are only able to use smart data fields, so discrete fields in the electronic health record. Things such as demographics, diagnoses codes, procedure codes, lab tests, and even questionnaire fields. Again, we can work with you on one-on-one to know what really can be used. The limitations with the tools are that we are not able to identify your cohort using chart notes. The other thing is that if you're really just looking for a healthy cohort that you could, identify outside of the electronic health record system, you would not be approved to use the tools. And if you are not looking for UCLA Health as part of your approved protocol, again, you'd unfortunately not be able to use these tools. And there are some limitations when it comes to sensitive populations that Antonia will be talking about later on in the presentation. And we do want to point out that if you do have a MRN list of patients that meet your criteria that you might have gotten from CTSI Bioinformatics, or via an approved IRB method, we are also able to work with you to use that for some of these tools.
I just want to pause there because there is a question from Isabella. If HIPAA waivers apply to accessing medical records from UCLA HD Center of Excellence. We haven't had experience with Center of Excellence, so I think we would have to look into that, Isabella. But we could take that back.
Next slide, Antonia, please.
Sorry, it was not moving.
That's okay.
There we go.
So we're just gonna show you some visuals of the different tools and highlight some of the different functionalities. But I did want to start off with saying that for any of these tools, they will be linked and associated to your IRB approved number, just so that you're able to get some metrics. And if your study is managed in Encore, you're able also to track, how many people have enrolled in your study using our metrics dashboard that we'll talk about a little bit later on. But as Antonia mentioned, we do have a MyChart recruitment tool available, and we do have two iterations of this. The first one, and the one that most study teams are encouraged to use, is our MyChart standard research recruitment workflow. And this one, what it does is there's a workbench report built out that identifies your cohort based on your inclusion-exclusion criteria. Our team then goes ahead and sends out a MyChart recruitment message to them on your behalf. And the patient will get a tickler message to the associated email with their My UCLA Health Portal account. And it will say that they've been identified as a potential research candidate to log into their portal to find out more. So they can either click the hyperlinked link there or log in, and then they will go straight to their research section, and your study will be the first one there available for them to click into. And then as you see to the right on step 2, they will get a recruitment message that's been IRB approved, and we typically recommend that it's very layman's terms and straight to the point. What is the goal of your project? What makes them eligible? What are you asking them to do? Is there compensation? And to provide some type of contact for your study team. And with this feature, they're able to either select, yes, I'm interested by using the button functionality, or saying, no, thank you. If they say they're interested, then your study coordinator will go ahead and receive an in-basket and Care Connect. There's going to be a whole new research recruitment subfolder that pops up. And when they click into those, it will allow them to see the patient's name, phone number, date of birth, and MRN. And to the right, it will let them know which study they're replying to. And then the coordinator is able to, whatever is IRB approved workflow to contact these folks, either pick up the phone and call them, or use the MyChart reply feature to say, thank you for your interest. Is there a date and time that we can contact you? And then we have what is our MyChart direct inbox message. So typically this is recommended for studies that are only looking to collect a one-time survey. Maybe you have a website for your project where people can self-enroll, self-consent. Essentially, when there's not a need for coordinator contact, we recommend this because it will go straight to the patient's My UCLA Health Portal inbox, and then they will receive your recruitment message, and it will have a link to wherever they need to be routed for them to complete next steps. The only difference between this version and the first one, which is the standard, is that in this one, you don't get that I'm interested, not interest functionality. So as far as metrics, we can only let you know how many people have, viewed or not viewed your message. Whereas with the other one, even though you're not receiving not interested responses, we are able to provide that data for you. And then the other tool we have available is the reporting workbench report. So this would be a customized report set up to identify your specified cohort. You do need to sign a data use agreement for this tool, where it will clearly list who from your study team will be needing to have access to this report and running it. And it has to be signed by your department chair and the principal investigator before anyone can be given access. But once it's set up and in place, your team can go ahead and run it as many times as you need it. And then you are able to then, again, based on what's IRB approved, pick up the phone and contact the patients. Or sometimes, a lot of times, these tools can be used if you're looking to really meet with the patient in person to consent them. It could be linked to an upcoming appointment. And then you would know, okay, let me call them. If they're interested, you can set up the date and time to meet them at their next appointment and talk about your study. And if they're interested, consent. But again, a data use agreement would be needed because you are receiving identified information before someone is consenting. The other tool we have available is a real-time notification or alert. So this tool is typically recommended for studies where, it's a clinical intervention where you are needing to enroll a patient before they're provided with standard of care or, perform a certain test. So typically, the alert will be set up again with demographics, if there's a diagnosis code you're looking for, but mainly if someone is admitted would be a good trigger, or if there's a particular lab test that you're using to identify your cohort, they need to test positive, let's say for RSV, for example. And then with this tool, you are able to receive the alert of the patient that meets your criteria through either a page notification if you're in clinic, an email notification to your MedNet, or a Care Connect in basket that will let you know who the patient is and where within the hospital they are. With this one, again, you will need to sign a data use agreement because, again, you are receiving information prior to consenting. And the other important element here is that your study team has to be working with the attending for the locations that you're interested in, because once you're alerted, you will need to go on site and you will need to talk to the attending physician. And only if they're okay with you approaching the patient, then at that point, you can speak with them about your study. And then finally, we have our provider-facing alert. So for this one, again, based on your cohort needs, it would run in the background, and whenever the patient comes in for an in-clinic appointment, the provider can receive an alert essentially when they open the chart. And then they click into that alert, and it will let them know that this patient is eligible for your study. It gives a very short description of the project, and then it has a few radio buttons that they can select based on your study needs for next steps. The big piece here is that your team is responsible for really communicating and getting an okay from the department or the providers that you're wanting this alert to be triggered to, because we can't just turn this on for the entire health system. So we just need confirmation that they're okay with this, and then it can be built out by department or provider type level. The other thing here too is that your team would be responsible for providing the education to these providers so they understand what your study is so that they can then speak to the patient about it, because it's very limited as to what can be included in the alert. But a couple of the mechanisms that could be turned on for this is that the provider will talk to the patient, and then they can document if they said that they're not interested by hitting decline, or if they are interested, they can press the interested button. That can land into your coordinator's in basket, and then they can, contact the patient with more information. Or if the patient says they need more time to think about it, or they want to learn a little bit more about it before they decide whether or not they want to do it, we could also build out for a MyChart message to go out directly to them when they click the Send My UCLA Health Request button. And then again, there they can say interested, not interested, and then they fall into your coordinators in basket for the next steps. Anything else you want to add for this one, Antonia? I think that's
it. No, I just wanted to kind of pause because it's a lot of information for these tools, and wanted to know if there's any questions specific to these tools at this time. Great.
And here's just a very quick snippet. As I mentioned before, with all our tools, we are able to report back on some metrics. For MyChart, how many have opened the message or not, who said interested, not interested. If you are in Encore, again, it will let us know how many people are enrolled. For workbench report to let us know how many people have been identified as candidates for your study. So in addition to that, we are able to then provide you with details as far as like race, ethnicity, age at an aggregate level, not individual level. But if you were interested in that kind of information, we are able to provide that by using these tools.
Insurance as well. We have some sort of great detail for what we can match with these metrics for you, which I think could be important when you publish.
And then just very quickly, we wanted to review kind of the approval process for these tools, as Antonia mentioned in the beginning briefly. But in order to submit a request to see if your study would be eligible to use the Care Connect recruitment tools, we do have a Qualtrics form that will be shared at the end of the presentation that you use to submit the details of your project, as well as some supporting documents. And then we review that information. We do an exploration of the available cohort, which is all used during a feasibility consultation that we have with your team to just review everything that, everything will be based on your timeline, your recruitment goal, kind of all those factors that we ask in that Qualtrics form come into play when we have that 30-minute consultation call. If, based on everything we have, it seems like you would benefit from using the Care Connect tools and the cohort is available, then the next step is to present to our recruitment committee, which means the first Wednesday of every month. We bring your project to them. If it is a MyChart tool, we also have to bring the recruitment message that you're hoping to use so that they can provide feedback or let us know if there's any additional questions they might have. And then after they approve, we give you the language that you would need to submit an IRB amendment because, again, it does need to be IRB approved. So we would provide you with that information to submit. And then once you get IRB approval, we just ask that you provide that letter for us and your final recruitment message. And then what we do is we put together a statement of work with all the associated costs and then send it over to your PI for signature. And only once we've received the signed SOW along with the FAU number that can be used to invoice when everything's completed, we submit the ticket to the Care Connect research team to be able to start on your build. And then there's a 6-week turnaround time from the time we submit your ticket just due to their queue. And the only one that maybe up to 8 weeks is the provider-facing BPA, just because it does require a little bit more testing on the analyst end. Let's see. I think that's everything in a nutshell. I think the only other thing is for the FAU number, we do ask for it at the time of signature for the SOW, but we won't invoice you until your tool is completed. And if you are using MyChart messaging, we would only invoice you after messages have actually gone out and the work has been completed, not prior.
And we'll go over costs in a few slides as well. Great. So now navigating to research recruitment registries, which really can be really good supplemental recruitment tools or just the main recruitment tools for your studies. Right now at UCLA, we have a mental health and smart health technology registry that has almost 38,000. I think this is like a week old, so probably close to 39,000 individuals that have registered, provided self-reported health information, and it fully engaged for studies around this focus of mental health and smart health technology. We have a diabetes registry that has about 8,000 individuals registered, a GI registry that has over 5,000, and most recently a UCLA wildfire research registry that has more than 4,000 at this time of engaged individuals ready to participate in studies. We also have partnered with Research Match, which falls under the registries because it is a national research registry database of volunteers that have registered on researchmatch.com to hear about studies and institutions. It's an NIH-sponsored organization from Vanderbilt, the Research Match, and they partner with other institutions such as UCLA And once we have sort of that partnership agreement, then we're able to use Research Match for our recruitment needs. What's great about Research Match, it has over 120,000 individuals registered. They also provide health information data. We can match them by zip code, by state, and whatever, even medications as well. So it is a tool that's available, and you would need to work with our team to go sort of through the process to get that sort of study registered in Research Match and start recruitment. Now, what's available in each tool, in each registry, I'm not going to cover all this data, but I wanted to display it so you can see sort of the health conditions, the type of information we collect in every registry. Just to highlight, our mental health collects the PHQ-8 and GAD-2 screening information. GI, obviously very specific to GI-specific health conditions and other. Diabetes, it's pre-diabetes, so it's individuals that have either at risk for diabetes or have diabetes or are part of the study or family history of diabetes. Wildfire is very specific to the zip codes that were under either evacuation warning or order. During the LA wildfires, it's very specific to the January LA wildfires. So there's ongoing studies using this registry, again, of very highly motivated individuals ready to participate in studies around the wildfire. And then Research Match, which I discussed. And as far as, one last thing, we do have an Embrace network, which is something we started piloting about a year ago, where really we envision trying to, how do we provide research opportunities really to our broader LA community and specifically our senior population in Los Angeles. We found through our recruitment efforts, it's very hard to engage seniors, especially even underrepresented seniors in research. So we came up with this concept of creating a network, which we call Embrace, that stands for Empowering Minorities age 55 and over by bringing research awareness through community engagement. So our concept was to partner with different senior active centers or community centers that are focused on senior citizens in Los Angeles to educate them about research opportunities at UCLA and also engage them for recruitment. And over the last 6 months to a year, we've been able to partner with 29 facilities that have over 1,700 seniors available and engaged around research. We've done a couple studies with these centers, and they're very engaged. These facilities, I've also opened up the idea of having a team come on site. Like if you have to ask them to maybe wear a device and they're walking around to measure their walking sort of different activity, we're able to do activities on site with these senior centers. And they're, again, very highly engaged. And we've been able to pilot different type of recruitment, whether we email them or call them or have flyers. And the most engaging has been when flyers are delivered to each senior center, and the actual coordinators at each senior center are very engaged, and they go door to door to the seniors to just let them know about the study opportunity. So highly engaging network, and we're very excited to offer this to UCLA, and hopefully other opportunities will come our way to these centers. For the recruitment registries, essentially it's the same process minus there's no committee that oversees this. It's really making sure the IRB approval is in place, the right language is used, the right, if there's flyers, that the flyers are approved, the messages are approved. And it depends on the registry. For any email registry that we're emailing out, it is about 5-day turnaround time. It's pretty quick from the time of approval when we can get the messages out for you. If we're talking about the Embrace network, which is a lot more engaging with the senior community centers or senior active centers, it is require a little bit more planning. So it really depends on what sort of study and what the recruitment approach is at those centers. Now, as far as cost is involved, we are a sales and service unit, so there is cost. So in the middle right there, you could see for approved projects that are looking for Care Connect tools, there is a Care Connect build tool that's charged by Care Connect Research, and it can be, most of them are 2,500 one-time costs for the tool to be billed. For a provider-facing alert, it does cost $5,000 for the tool build. And this is really just covers the Care Connect research analyst time to build the tool custom to your study. There's also a project management setup fee tool, which does the testing and working with them, which is $438. And after that, there's no more other costs unless you're planning to use a MyChart tool, and it's $91 per blast, which is up to 500 messages per blast can be sent. So 500 patient messages at a time. We are limited to 500 just for per IT security guidelines. Now for recruitment registries, there is no custom built tool. It's just a cohort that we pull from the recruitment registry with our data honest broker. So just a one-time setup fee of $438. And then every blast that we send out is $91 a blast. Any question at this time around the research recruitment registries or tools up to this time? All right. We did touch on sensitive populations, and I just wanted to list these sensitive populations. There are some challenges in building the tools that we covered or being able to develop recruitment approaches for these cohorts. So there's sort of challenges with each of these groups, and I just wanted to make sure I list these here for you all to keep a note of. So it really depends on the type of study that you're running, if it's a treatment intervention versus observational, on how we can use sort of what we can do to identify these individuals that fall in these cohorts. Something that's coming up on the horizon, and I just wanted to sort of put this here, we are launching a digital gap program that is coming in July. This is in partnership with Verizon, where we partner with Verizon to be able to provide to our study teams a very, very cheap monthly fee of a cell phone, which is about $20 per month for a 1-year contract that you can provide to study participants that have a hard time, that you're having a hard time to reach. Maybe that it's really focused around individuals that just maybe don't have a phone, don't have an unlimited data plan, don't have a working email, to be able to provide them an actual cell phone that is really, really low cost for study teams and that they can budget into their grants and funding. So that's coming in July, but if you're interested, I'm happy to set up a call to discuss a little bit more if you're prepping a grant around this, because it is a really low cost way to provide cell phones to your study participants where a barrier is the digital gap. So that's coming, more to come in that area. Second, we are looking to launch, I think next year, an approach to be able to send texts or emails to patients that don't have a MyChart and still can receive a research recruitment message using MyChart without having a MyChart account. Epic is going to be rolling out that soon. I think it's going to be available for us in spring of next year. And lastly, campaigns features, which is another feature of Care Connect Epic, which essentially is going to start being where we can automate recruitment messages to patients that meet your study criteria and program them without a manual need to email them. So that sort of at cost messaging that you're seeing that we are charging $91 a blast, that can be replaced with just automatically setting up the schedule for sending recruitment messages. We don't need to manually send those messages out. The campaigns feature can schedule those and automatically send those out, which is going to be cost savings. So that's coming soon. Just wanted to put that here for everyone to know. Some other services our team does provide is other study development, study support, and REDCap, just general study development, study support, and any kind of study survey builds in REDCap as well. And if you're looking to submit a grant or need recruitment support or just want to kind of get a feasibility review of an idea or concept that's coming your way for a study, we're happy to meet with you This is the QR code for to complete the intake form to set up a consultation with us, which is free, no cost. And our website here. Any questions? I shall just stay here in case others want to scan it or. Seems like there's no questions. Hopefully this has been interesting, and hopefully you all can find this useful in future studies or current studies.
Thank you so much, Antonio and Liliana. That's it for today. We will send out slides and a link to the recording. And thank you for coming. See you at the next one.